So today I'm going to illustrate to you how we fix aneurysms with models that I brought home from my office, and try and give you an idea of what to expect if you ever need to go through these surgeries. It's hard to kind of describe what open surgery feels like. It doesn't feel good. It's a safe surgery. You want to be in the hands of somebody who does a lot of these open aortic surgeries. Back in my heyday, there was no endovascular techniques, so we fixed everything with open surgery. But essentially, if you can't get your aneurysm repaired endovascularly, open surgery is actually fairly safe in good hands, but it's a big operation to go through, meaning that you'll be in the hospital 5 to 7 days. You just won't feel great for about 4 to 6 weeks. You may have episodes where you're nauseated, you're going to lose weight because you won't want to eat, your appetite won't be great, you'll be stiff and sore, you may have diarrhea, you may have constipation. There's a whole host of postoperative things you have to go through. But essentially, think of this stuff as like plumbing. It's plumbing. You got a bubble in that plumbing, and in order to fix it, you have to go above it and below it to control that blood vessel so that you can replace that segment of it, okay? And so let me just show you on this model. I'll show you the back part of it. So this is what the aneurysm kind of looks like. It sits slightly to the left of the midline. This sits on your spine. And this is the aorta coming down. These are the kidney arteries. Here's the aneurysm itself, and here it splits into the blood vessels that supply your legs at about the level of your belly button. And so in order to fix this thing with open surgery, let's just say, you have to control it below your kidney arteries here and below where they finish off here, the aneurysm extends to. You have to control those blood vessels, and then what we do, you get a midline incision in your belly. It goes from about the level of your xiphoid bone here all the way down to past your belly button. So, good 6 to 8 inch incision. There's also retroperitoneal approaches, which probably are a little bit less painful, where you're going through the side, but essentially the crux of it's the same. This segment of the aorta has to be replaced because that's the aneurysmal segment. So above and below it, after the exposure, and then fixing it. So the anatomy is such. It sits slightly like this, and then the duodenum, the first part of the intestine, lays over this. You have to elevate that. The kidney vein is usually sitting around here, the left kidney vein. So this is the left side, obviously the right side. So the left kidney vein drains across it, usually like this, into the vena cava that runs parallel to the aneurysm. And so we get this all exposed, and then we give you blood thinning through your IV, obviously, while you're asleep. Clamp what they call the inflow and outflow. The inflow is this part coming in, the outflow is the part going out. Clamp it, open up through the aneurysm, and there's usually often what we call lumbar vessels, collateral blood flow vessels that you have to tie off with suture. And then essentially you replace this segment with prosthetic material. This is the open surgery, and I'll talk to you about the endovascular repair shortly. But essentially you replace this segment with the prosthetic material. Now you're dealing with vessels. This aorta is about, in a male, about 2 centimeters in size, 1.5 inches. And women maybe a little bit smaller, but essentially you have to replace the segment by sewing in material. And then once you get done sewing it in, then you unclamp everything and let reestablish blood flow to the legs, and then close everything up. Okay, so the material that we use, I didn't have any of the regular stuff. I had this old graft. Now this is an old Dacron, what we call a Dacron woven graft. This is obviously small. This is not what we'd use for this kind of bypass, but it's stretchy, and obviously we'd use a much bigger caliber one for this. This is actually the old woven Dacron, where we'd have to pre-clot it with your own blood. Nobody the younger guys don't ever do that because the new grafts are so nice. They're already pre-clotted, so they're already baked with stuff so that it doesn't leak. But in the old days, you would have to take your blood out of your vena cava, inject it in here a few 5, 6, 7 times to make all these holes in the graft kind of occlude, and then we could use it. In the new days, now the grafts just come off the shelf pre-clotted, so you don't have to muck with it. But essentially, this is what the material we use, Dacron. There's also Gore-Tex you can use. Gore-Tex is what we sometimes use for bypasses too, and it's Gore-Tex is you know, in windbreakers, same material, Gore-Tex, polytetrafluoroethylene, synthetic compound. So sew it in above, below like this, unclamp, reestablish blood flow. So works great. It's been done for many years. Results are great. What's the biggest deal with it? Well, I mean, the surgery is a pretty big deal. I mean, you know, you don't feel great for a while. So the risks of the anesthetic, having a heart problem during surgery, infections, pneumonias postoperatively, kidney problems, infection in the long run. I mean, this is a piece of plastic tubing sticking inside you. I often get asked about rejection. You don't so much reject these things as potentially get infections in it. Now, all complications to the open surgery should be less than 4%. You know, heart attack, all these other things, less than 4% in a big center. So you got to find a place that's doing plenty of them. The problem is there's actually decreasing numbers of open surgeries that are done. Now, the younger guys coming out now don't quite have that exposure to the open surgery that the old folks like me did years ago, because that's all we had. So, but the younger guys may be better at the endovascular techniques than us old guys. So, fair trade-off. But anyway, this is the standard open repair using this material. Obviously, a bigger graft than this. So that's the open repair. Now, the endovascular technique is much better tolerated because it's much less stressful on you. So the endovascular technique, you essentially end up with 2 little groin incisions about yay big. It's almost percutaneous. You end up with these little groin incisions, what's called a closure device is used to close the holes, but essentially you get into the aneurysm from the groin arteries, and then you deploy a graft material. It's like, it's not Dacron usually, it's Gore-Tex usually, or PTFE, with self-expanding nitinol sewn onto it. Nitinol is, I think, nickel and titanium, if I remember right. But essentially, when you expose it to body temperature, it becomes more rigid and hard. When it's cooler, it's more flexible. When it expands into body temperature, it expands into place, it becomes more rigid and hard. So so here's the aneurysm. You go in through the groin arteries above, you know, get a control of this thing, and then you got to deploy this thing underneath the kidney arteries. So you got to have enough room there, and there's different measurements that we make, and then enough room down here. We can sometimes extend it. These are the blood vessels to the pelvis area here. So if we cover these, sometimes you'll get a devastating complication could be that you get lack of blood supply to your colon, and that can be a disaster. But typically, we don't need to cover these things, or we can arrange things as branched grafts we can do to not cover these blood vessels here. The ones to the colon and the pelvis. You know, in males, if you cover this thing, you'll have troubles with erectile dysfunction. And so anyway, the whole thing is replace this aneurysmal segment so that the blood flow goes into the sac, into the repair rather than into the aneurysm sac. So it kind of ends up looking a little bit like this, because this is stylized, right? So here's the kidney arteries, the device is deployed, it's underneath the kidney arteries, it comes down like this. Usually we have to have a short limb on one side that we have to recannulate and kind of extend it and puts it into place, and then you take a picture and make sure that all the blood flow is going in this way and not around these areas, because that needs more work, or around these areas. So there's certain types of what we call endoleaks, leaks into the aneurysm sac that are acceptable to leave alone, but certain types are not. What they call type 1 endoleak is not for certain. So this is kind of the model of an aneurysm replaced. So the blood flow then goes down this device and out into the legs rather than going into the aneurysm sac. So that's an endovascular aneurysm repair. The nice thing about this is you stay in the hospital one day and go the next day. Now that doesn't mean that there aren't potential complications to any of this stuff. You know, you're dealing with these diseased arteries. They can tear when you're trying to push these devices up because they're they're big sheaths that we put in there. But essentially, once you get this thing in and pull out the sheaths, you can use what's called a closure device that closes the hole in the artery in the groins, and then you spend one night in the hospital, go to the next day. You just have to take it easy for a few days so you don't tear anything open in terms of your groin incisions, but much easier to tolerate. The recovery is much quicker, and most people really go through this endovascular procedure well. But sometimes it's better to have the open surgery. I think that discussion needs to be made between you and your surgeon. There's other physician modified grafts that can be done by good technical surgeons, other things that are available, but generally speaking, that's the endovascular repair of the aneurysm. So I think things are trending towards the endovascular repair because it's much better tolerated. I think somewhere down the line, it may be just an outpatient procedure, honestly, but that depends on technology advancing. While I picked up those models, I got a couple more things I thought you may be interested in. So back when I was starting my career, this is what's called a greenfield filter. This is the filter device that we put into people's veins. Now, this is the old greenfield. It has no hook on the top, so this is a permanent filter. This stays in permanently. If you look at if you get a closer look at that, it's got little hooks on it that hook inside the vein wall. So it's put in through a small, into a tube like this, put into position. Again, when you deploy it, it expands into place and hooks into the vein wall, and that's how it works. So if a clot's coming up from the legs, this thing traps it and doesn't allow it to keep going upstream, prevents it from going to the lungs. Now, it won't stop the smaller clots, but those aren't the ones that usually get into trouble. It's the big ones that cause problems. So that's the permanent greenfield filter. And then I have a temporary filter. So again, same way, it's loaded in through a tube like this. And once you position it underneath the kidney veins, it's deployed, opens up, hooks into the wall. There's little hooks on the end of this thing, if you can see it, hooks into the vein wall. But this is a temporary filter. So temporary in the sense that it's got a little hook on the end that you can, at a later date, snare from the top using a snare device, capture this thing, push a sheath over to retract all the legs, and then take it out. Okay, that's a temporary filter. Generally speaking, you want these things taken out fairly quickly because the longer they stay in, the more difficult they become. If they come really wedged into the wall of the vein over time, after years, then you have to use these specialized lasers and techniques to get them out. But we used to use this a lot when it first came out, but we don't use it quite as much. I think we kind of overused it, honestly, because it was, you think that, oh yeah, this is going to be great because it'll prevent blood clots, in these high-risk patients who are going through, like, for example, an orthopedic procedure or spinal procedure. But in reality, it probably, there's been studies on it that it doesn't make a whole bunch of sense to put these things in as much as we used to years ago, and there's some potential downsides to them. Like we talked about, if the vena cava that this sits in clots, then it's a real big hassle, to treat that. So we're not using them quite as much as we used to, and I think that's probably a good thing. But anyway, this is a vena cava filter. I thought you'd enjoy seeing that little thing with the little hook on the top of it. Anyway, tomorrow I went to see my heart surgeon today to talk about my mitral valve. So I'll talk about what we discussed and kind of give you an update on that. Anyway.